Carlos specifically for inviting me to this event. It's a very interesting event. I'm fascinated by the presentation of Madame Pilar. It's a very rich presentation. It's a very rich debate, and I think that is the whole purpose of promoting or raising awareness of the purpose of the WHO Global Code of Practice. Madame Pilar has made my life very easy because she has given a very interesting and comprehensive background to the code. I'm also happy to say that I am meeting her for the second time. We met last September in Oslo, Norway, when we were discussing the set of commitments countries can put forward to support the WHO Code of Practice as a focus of the discussions. But as she has shown nicely, the Recife Declaration moved on to include a comprehensive picture of health workforce development as a whole. And what I will try to do, I will not take long because I'm aware the time has passed a bit. But I think it's all in good purpose because the previous presentation was quite informative. I will just give you a brief background about the purpose of the WHO Code. And I will want to reflect a little bit on the global picture because I think we need to also show you the real objectives and the motivations of WHO behind the code. I think I already said this, so I'll just quickly move on. Basically, what has happened in 2006, WHO came up with a very important document for the health workforce development movement, if I can dare call it that. We have a flagship publication in WHO called the World Health Report, which takes a topic of priority each year, and it reflects on the global perspectives related to that topic. At that point in time, the big priority was health workforce, coming after initial work that was actually generated by a group of research and policy people called the Joint Learning Initiative, put together or supported by the Rockefeller Foundation. And as Madame Pilar has said, the trigger of that has been the fact that there was a clear evidence that, first of all, health workforce data globally is not in good shape. Health workforce constitute the core component of health systems, yet information as a whole, it's actually always suffering from deficiencies, and in many occasions, the understanding of the health system happens on ad hoc basis of planning. And I really sympathize because what you are observing here in Spain is not different to many countries, what we can term developed or transitional countries, as well as the fact that there is a very big relationship between a simple metric like health workforce densities and health outcomes. We will come to that. As you have seen from that report, 57 countries were triggered as very high risk countries who are really falling behind with their distribution in the sense of their densities of health workforce in achieving what we say are optimal health outcomes. The focus of that outcome, we will come to it later, is mainly maternal and newborn child health, and this is driven by the Millennium Development Goals. Sub-Saharan Africa, for example, as you will see from this slide, it has 4% of the global health workforce. Yet, it bears 25% of the global burden of disease. Compare that to the Americas. By that I mean North and South America. It has 37% of the health workforce. 1/3, 1 in 3 health workers, you can find them in North America and the South American countries, whilst they only have 13% of the disease burden. So that triggered a lot of debate. Where do we start? The first examination that went into it that actually determined the 2.3 density is the fact that we picked on a few health outcomes, the key ones related to the Millennium Development Goal, and associated it with the health workforce density. On the right side, you will see the blue countries, the dark blue countries are the ones, for instance, suffering the highest rates of maternal mortality death. If you look at the orange side, you almost see a mirror image. These are the countries that are having densities of health workforce that are lower than the 2.3 mark you have seen. 2.3 physician, nurse, and midwife per 1,000 population. I liked very much the presentation before me because the focus, as you can see, is still these three cadres. These three cadres constitute a certain percentage of the total cadre force needed to cover the full health system's requirements. Why did we focus on this? Again, driven by data availability. So that is why the issue of enforcing data and enforcing better understanding, the huge effort that's going into understanding registry data, where are your doctors, inside the country and outside the country, where are your nurses and midwives, this is a huge movement that could forward the agenda on health workforce development. This is a very muddled up photo, but I just left it in there to tell you a little bit about our focus in WHO. Basically, that report separated three phases of the health workforce life cycle. There is an entry point, an in-service and activity, and a sort of an exit point. We like to believe that maybe the majority of the health workforce rotate within this without skipping a phase, because for instance for exit is the natural attrition by retirement or by out-migration or by altogether giving up work in the health sector. So we kind of spread our work to support all three phases if we can. I'll take you first to the right side. At the entry point, we really push a lot of work in strengthening, this is again part of what the presentation previous said, understanding the needs, the skill mix that is needed to serve the current health priorities within the health sector in each country, improving the education, improving training, adaptation to new technologies. All of that is what we have done by supporting some guidance on improving the quantity, quality, and relevance of the health workforce. We launched those guidelines when we were in Recife, and the WHO Code of Practice, of course, is part of that whole picture of how WHO is supporting different elements of that of this framework, all in aid of coming right to the right-hand side where you see the improvement on health workforce performance. You really want to see the right qualified people with the right skills in the right place, doing the right work, and producing in the most in the most appropriate setting with the right facilities and all, and producing the right sort of outcomes do you want, which is to ensure health for all, as Madame Pilar has indicated earlier. This is a key priority for WHO. The code, I will go through this part quickly. It is the second type of its nature in the history of WHO, the old 6 decades of WHO, a voluntary code. All 193 member states at the time assigned to it. It was a tough negotiation. What was the crux of the negotiation is, what do we do? Do you curtail movement? That's of course a human right, you can't. Do you offer compensatory packages for sending countries? It was a very heated debate, and it was definitely a breakthrough to see it happen. It's a dynamic framework. We need global dialogue. We need exactly what is happening today in this room, because guidance and information that will be gathered from such an event, it's not just for your local consumption. If it can rise above the use of whatever is being debated in Spain, it has to flow all the way up so that it can be shared regionally and, if possible, with HQ, with WHO, so that we can actually show countries how the actual dialogue is done and where it can lead to real actions for better health workforce planning. The information exchange, as I said, my previous speaker did a good job to actually give well-demonstrated example of information exchange. This is vital to understanding migration. Migration is a very dynamic process. It is not a process whereby we can have an excellent tracking system to understand movement. Otherwise, it becomes a very exhaustive process. And that is why the reliable exchange of information is vital to understanding how to best support the code implementation. The code has 10 articles. I am not going to go over them one by one. I would like just to laminate the speaker from the Spanish Foreign Development or Foreign Affairs made a very good point about the role of not just understanding your domestic solutions, but aligning them to what your international policies would also want to promote. And Spain has a formidable record in improving a lot of efforts through the European Union and even by Spanish aid on international development and technical cooperation. So this is exactly one of the key things that is promoted via code. The data gathering and research, of course, is something you see. And then the actual implementation of the code. I think we need to understand first the landscape of what's needed. We need to have as many stakeholders aware of its purpose. Those stakeholders can be anything from the ministerial departments, recruiters who operate freely, and they operate in two dimensions, either as sending, they actually facilitate migration, out-migration, or as recruiters to bring in labor force into Spain. The employers, the professional organizations, and the code says that this has to be the amalgamation of all the stakeholders who should come in and discuss the issues related to migration. As Madame Pilar has already explained, the focus of what we wanted to do first is to help every country voluntarily nominate a national authority that could take that leadership role. And the letter that went, the verbal note that went, left it to the freedom of the country to actually choose what sort of authority would be best suited to give us and exchange information on the code implementation. And the profile, we did a global analysis. Almost 75% of the countries that reported on the code let that role be with their Ministry of Health. Other ones used health authorities that are independent from the Ministry of Health, but the majority have gone for the positioning in the Ministry of Health. We devised a small assessment instrument, and I will go straight to tell you about the results. The instrument gathered information as best as can be in the 10 articles of the code. Let me tell you about the reporting first. WHO has 6 regions. You see them from up to down. They start from the Western Pacific, the Southeast Asia region, the European region, the Eastern Mediterranean region, the Americas region, and lastly the African region. As you can see, the dominant region has been the European region. We have 53 member states in that region. 43 of them managed to designate a national authority, and 40 actually managed to report. So the reporting rate is more than 80%, which is quite interesting and quite encouraging. And the fact of the matter is that the majority of those countries, and maybe at that snapshot of a time, we do regard Spain as a receiving country. Perhaps this profile, as we just heard, is changing. Unfortunately, the reporting has not been as optimal as we thought for the other regions, but the factors that affected this are multiple. I think the way many countries interpreted the questions that were triggered by the national reporting instrument lent more on rights and recruitment and whatever, but they didn't exactly reflect on the fact that they could also report on their national policies to improve retention, for example, so that they can incentivize and retain their workers. So that's why the national reporting instrument itself will evolve so that we can trigger more and stimulate more the national reporting. We work in partnership. WHO is keen to really tap on all resources that are available, the role that is played by all the NGOs, the civil societies, partners like the OECD, the ILO, the IOM. These are all what we call migration-associated organizations who are trying, of course, to have their own angle of interest, but the code has become more or less a unifying factor for them to work with us. I want to speak about our initiative with OECD. Madame Pilar spoke about a little bit the exchange of information, but she is absolutely right in the fact that migration data, even to characterize it, what sort of information you need, is a very hard job. What we are trying to establish with OECD is a group of questions or information that we can collect. That pyramid can show you. For instance, at layer A, we are asking for the current workforce that is serving in these countries to see where is their country of first qualification or first training. Because that probably would be the highest common factor to actually detect mobility. A Spanish doctor trained in Madrid, but he is serving in a hospital in Sweden. Sweden, per the agreement between OECD, Eurostat, we call it the triad, OECD, Eurostat, and the World Health for All database in Euro, can be requested to actually tell us how many of the currently serving Spanish doctors in Sweden have gained their first qualification in Spain. This is a very huge effort. We don't know whether it will work or not, but we will give it a try. We will not burden these countries by these questions every year. We are trying to insert it as a rotating module that appears every 3 years, which will help us report on the code implementation. It will substantiate our platform of reporting. And the purpose of it would be that we will have the odd 60 countries who can do that, and we can maybe take the burden, the flooring of the reporting, so that the national authorities can actually do more on understanding the local actions that are more around the education, the training, the deployment, the issues related to the labor market, how much are you producing and how much are you absorbing. So this is still work in process, but we seem to have a good understanding between WHO, OECD, and hopefully Eurostat will be our third partner. That will be called the minimum data set. This is a kind of a cliche name, but we're not sure yet exactly how many questions will appear in there, but we'll do our best to have the first country of qualification, the current status of employment, and some biodemographic data. I'm here today to tell you about a very big effort we've made in WHO. I will tell you quickly, I will concentrate in the final part of my presentation to tell you a little bit about the findings from this book. We had to embark on a publication to gather a lot of country experience that we have seen when we asked for the global monitoring of the code. Basically, we had, first of all, the presence of more than one actor. The civil society features strongly in this book, and I'm happy my colleague Julia Duponte is here. She will speak in the later part, because we felt we needed to do more than what the small report we have to do to our World Health Assembly. There is a lot of knowledge to be shared. There are a lot of actions in countries that have been triggered by the code or just before the code was adopted. So we needed to honor all of these different movements so that we can speak more about what's being done to improve the understanding of the health workforce distribution, meaning availability, accessibility, accountability, whatever all these elements are, and at the same time to open the eyes to the demands of the future. For instance, we give a chapter on the global progress, which is more or less the snapshot of the histogram you saw of how many countries reported, what are the priorities within each. We have a legal evaluation of how the code could be in a way ingrained or mandated within the regulatory frameworks of countries, and that comes from El Salvador. We have specific country experiences, small countries like Norway, Switzerland, and big countries like Philippines, a key source country for specifically nurses, and they are really outspread. They really are a global distributor of health workforce. Countries like Switzerland are suffering from issues that probably you will see very soon in Spain: remote access. They have remote health postings where they cannot deploy. young doctors in training or nurses and midwives will not be in a village that has 1,000 individuals living in the top of a mountain. So, it's a very interesting mix in the sense that the problems are the same, but the solutions that will come to meet them will vary from one setting to the other. We have a chapter from the OECD countries where they really tell us about their data sources. It's actually the flooring of the rotating module that I spoke about. It's where it actually makes the case that such information is so diverse and complex, and it is better to be aligned in one module or one means of getting the information. And then we have 4 in-depth analyses of 4 countries: Australia, Canada, the UK, and the US. The choice of these 4 is not just a random one. Between them, they have almost 2/3 of the health workforce working in the 25 OECD countries. They are very high recipient countries, and each one of them has a different story. My favorite one is Australia. Australia, 10 years ago, they woke up and realized they have a big problem of an aging health workforce. 25% of their health workforce are above the age of 45. They decided that they have to open occupation-based migration so that they can arrest the effect of their aging health workforce. The way they arrested it is that 10 years on, that percentage is still the same, 25%. This has implications. It means the country had to take into account its labor market analysis, at the same time its needs requirements for the planning, and to size that up relative to who you have today and how much you can produce is the answer to how to prepare yourself for the coming 10 to 15 years, and not to leave it to a situation of ad hoc filling in the blanks, That is why this effort that is spoken about in the registry, this is exactly the foundation of how you can gauge who do you have. And if you really can gauge as many as 3/4 or say 50% of your professionals, meaning the cadre, I don't speak about 1 or 2 or the bulk of the service delivery cadre, this will be the breakthrough establishment. Because it's not specific to Spain. Most of the globe, they have no understanding of what is the full spectrum of their health workforce, because, as you said, the sector variability, public, private, the inability to measure out migration. You might be producing adequately, but you are not able to retain or deploy from whatever you have, the supply and demand, labor market analysis. So I think this is one of the very interesting experiences that we need to keep an eye how it unfolds in Spain. Key messages. The economic crisis, this is something, if I can give you a message to take home. As far as we can see from the snapshot of these 13 countries that we studied, especially the top 4 that are the biggest recipients, we can see that it has not as yet had a significant effect on the health workforce migration. Not as yet. Why? Because what we see is that the sectors have been stable. The health sector spending has been stable. In fact, in the US, it grew from 9% to 11%, and it is expected to grow more with the Obamacare bill. So that means they will have to rely on importation. They're not producing to their scale. So we need to do an analysis again when we report for the Code in 2016 to see whether the effects of the financial crisis are coming in via just the fact of what you've said earlier, that there can be a cut in the health sector employment, that it's not employing as many as it would be, and hence there would be a kind of a loss to migration, that people will have to be mobile. Yeah, that's my last slide. The demand for the healthcare is expected to increase. You have aging populations, you have an aging health workforce, and of course you have all the new agenda transferring care from communicable to chronic. You have new technologies that are replacing some professional work and remodifying training. So all of that is going to impose a rise in the demand for healthcare, for health workers. This is a ripple effect. The code is a mechanism. We are trying to put it at the centerpiece. It includes many dimensions, but it's a common sort of a goodwill that we hope we can all attribute part of the achievements to improve the situation of the health workforce to somewhat a code principle or a code dynamic. We need to keep monitoring. I like very much the fact that Spain took in 2011 the step to modify the code to suit its purpose and its needs. That's exactly the purpose of it being a voluntary code. This is not the Tobacco Convention. The Tobacco Convention, you cannot deviate 1 millimeter from the agreement that has been signed by a country. And that is the power of the code of being a soft instrument. Finally, I leave you with one thought. We work with the World Bank. And of course, the World Bank talks money, talks about remittances and the big size that it contributes to countries' development, economic development. I took this snapshot from their last monitor. It's called the World Bank Migration and Development Brief. The top 10 countries receiving remittances from migrants. At the top end, India, 71 US billion dollars. India is the #1 source country of physicians in the world. Yet, when you see this remittance data, you cannot segregate how much of it is due to health sector, meaning physicians and medical force, in general health workforce. But you know that we have to be realistic. The code will not work by curtailing movement. Movement improves knowledge transfer, technology transfer, remittances. So we just want it to be done in a responsible fashion with enough awareness of planning and projection. This is the core of it all, that there has to be enough awareness of need, demand, how much of that need you can meet economically, and supply. It's a very simple association. Percentage of GDP, I've put red markers on all the 57 crisis countries that are featuring, like Nigeria, Bangladesh, Pakistan. And the percentage of GDP, please look, Nepal and Lesotho, 25% of their GDP is from remittances. So for me, this is a reality check, that as much as we will try to understand the implications of migration, it comes with a money tag. It comes with some understanding also of the financial benefits that unfortunately will compete with other interests related to health sector planning and projections. Thank you very much for the opportunity.